Hi there, I'm Dr. Stephen Phelan. Welcome to this video. Today I have a full mouth rehabilitation case study for you. This is for a super patient, real nice guy who was suffering from some severe erosion and tooth wear to the point where a couple of lower bicuspids were eroded right to the gum line and needed to be extracted. So let me share with you this case. So here are the before images for this patient, a couple of them. And I'll point out that, I feel that this is the kind of case you can complete by implementing the systems and coaching that you can learn with an occlusion design membership. I do share these kind of cases on a monthly basis. And in fact, this case was the February 2023 member webinar. We shared it in a couple other webinars, but this was the feature in February 2023. And I showed a number of clinical videos from the case. I'll share with you a little bit of this, of the content from this webinar, just to give you a feel, but also to let you see how I managed this patient's treatment. So this is just showing you the February 2023 member webinar. It was 2 hours and 50 minutes. And I shared this case. We looked at some member cases as well and answered all Q&A. And so here is the patient beforehand. This is the before lower. This is the before upper. I had a consultation with Dr. Nahid Mohammed, Dr. Yosef Nemias, trying to figure out if we wanted to try and keep these teeth with crown lengthening and endodontics, but neither of them felt it was a good idea, nor did I. I just felt that we need to be thorough and have these consultations. What we decided on was immediate implants for the 3 bicuspids with custom healing abutments. So immediate implants with custom healing abutments. So I sent the patient for a CBCT at Canarray here in Ontario. I use Canarray because it's just simple. It's a radiology clinic and group. They send me a report. They send me the case set up in Implant so I can plan out my implant placement and order a surgical guide. So I had Nahid kind of consult me with the implant placement and the design of where we were going to place them, basically subcrustally. I watched the immediate implant placement module in aesthetic implant protocols from Dr. Nahid Mohammed. Now that's more anterior cases, but it applies to bicuspids because they're very similar to an anterior case. So I followed his protocol. It was amazing, worked out great. Followed his protocol to make these custom healing abutments, which worked out really well too. And the advantage of that, especially with an immediate implant, is you're maintaining the soft tissue and the hard tissue outline form as opposed to using a stock healing abutment that doesn't really go out in that, oval shape that a bicuspid has, especially when you cut it off at the root level. So, I think that this was a really good service for the patient. I did this as the initial phase, plus some gingivectomy and some changes, and then let that heal. And then we went to the full preparation days. So this is the healing abutments. This is a couple of other views of the patient before we did the implant surgery. Here's another view. You can see the radiographs. And here's the planning and Implant planning. Each individual implant, we planned them longer than the original roots and subcrestal. So longer and subcrestal, we had plenty of room above the nerve, and we had some good apical bone to engage the implants. Here's immediately post-surgery. I did all 3 at once, as well as the custom healing abutments. Probably took me longer to make the custom healing abutments than it did to actually place the implants. That's just the way it is. These are kind of time consuming, but they give me the maintenance of the, outline form of the previous tooth. So you can see here, nice support for the outline form. I think that this is a critical step if you're doing immediate implants to get the best result. You can see here, nicely supported. Here's a video post-surgery that day. Just shot this on my iPhone. Here are the radiographs. You can see Nahid recommends that you place these subcrestal. And, he didn't have really thick tissue above them anyway, so this allows us to thicken up the soft tissue as it all fills in and heals. Here's the custom healing abutment before I cut the top of the stock abutment off of it. And then we let that heal and we go to our 2-day rehabilitation prep process. For me, I get a wax up done. So I took some new records because we altered the gingival level of the upper anteriors and we did the implants. So I had the wax up completed analog. So this was an analog case. We did the wax up in wax. You'll see other cases from me where we were doing digital design and even scanning the patient, but this is analog. And we did the wax up in wax from new models that we took of the patient after everything had healed from the alterations that I made. We took polyether infragum impressions, so they're the most accurate for this wax up. New bites, and Harold Heindel, my master ceramist, did the wax up. And day 1, we were prepping the lower. So we're doing lower core buildups, lower crown preparations, lower custom implant impression transfers, lower final impressions, lower provisionals, but no lower bite records. It makes no sense to take the bite records this day because you'd be taking them against the upper that's not like the shape that you're going to be working with. So part of this case, we were debating also, do we use crowns on the lower incisors? And I was torn. The enamel was very thin on the facial of these teeth, and the incisal edge was worn down. So I felt in the end, I was going to go to crowns. The bicuspids, or the cuspids, was no question that it was going to be crowns because the whole facial wall was eroded. The incisors had a little bit of enamel left, but I was concerned that, it wasn't going to be a quality bond for my veneers. So we just went the more predictable route and did this case with crowns. I did core buildups on all of these teeth and even these molars. This particular molar, sorry, this is a reverse image. It hasn't been flipped. This particular molar here, I did composite bonding to build it up. It wasn't as bad as all the others, so I decided to keep it in its current state. And I did the composite bonding. I believe I did it after I had made the provisionals on both arches. So day 1, again, we're doing all of this. Here's everything ready with the diagnostic wax up, the duplicate model, all of the things that I needed that day. That fluorescent one, I would say, is close to BL2. So we were talking about shade as well for the provisionals. And so here was after, custom impression transfers, because I had custom healing abutments. I want to capture all of that. So we did custom impression transfers, open tray. And you can see all the buildups. In the posterior, I used white core paste, white opaque core paste. In the anterior, I used tooth colored core paste. And I did do cores on all 6 anteriors. You can see how the the custom impression transfers are maintaining the contours that the custom healing abutments had. So we showed all of this in February 2023, how I make these custom impression transfers, prepping the teeth, doing the core buildups, etc. And I'll just show you a little clip from that. This is just putting the custom impression transfers in place, having the retraction cord in place, and getting ready to do the final impression. It's a bit of a challenge, this kind of case, because you've got a lot going on here. And I did a lot that day. It was a long day. Patient was really good. He held up really well. We do give patients for these kind of cases, generally I give them some triazolam. And I put them on a pulse oximeter because it's unpredictable. Some patients with triazolam, they actually fall asleep and they're snoring and they're really out of it. And I'm only giving a small dose. So we put them on the pulse oximeter just to be safe, and I'm monitoring their oxygen saturation, blood pressure, etc. And it just makes me feel comfortable when they fall asleep that everything's good. And then you can see the impressions. I actually took two. I took the one with the custom impression transfers, open tray, and there was, it was a tough impression. I had one little pull over here or area that wasn't perfect. So I put in some stock, basically closed tray impression transfers and did the impression, got the tooth that was not perfect, in the impression. Everything else was really good. And basically, we used this to make the die on that one tooth. The rest of it, the case was built on this. And it's just, there was a little tear here. It wasn't quite perfect. You can see here the impression. There's the one where I think there was a little tear. And there's the better one. So just as a precaution, because I'm putting all these provisionals in, I'd rather have an extra impression if I feel I need it. Day 2, we're doing upper core buildups, upper crown preparations, upper final impression, upper provisionals, and if possible, I would do an upper prep to lower provisional bite record. Now, after the patient's been through 2 days of this, basically 2 days of prepping, their muscles might be pretty fatigued and you may not get a very good bite record. So I always plan my provisionals out so that I could take the bite record down the road if needed. And so what we do is we section the provisionals. So I have splinted provisionals generally. I'm not doing 14 or 12 upper provisionals individually. I do them in sections. So we did, I believe, cuspid to cuspid, and then the bicuspids in the first molar and the second molar on the one side in sections. So I just cut my provisionals, and then I'm able to take out the posterior sections and have the patient take the bite record that way. We're able to take out just the posteriors. I can leave the anterior section because it's got the vertical, the overbite, the overjet. Everything's dialed in, and I just have to take out the posterior provisionals and take the bite. So that's another tip for you. This upper, I left one molar as well. So I left this molar over here, and I just took out the resin and did a composite on that molar because I felt it wasn't really in bad shape. It was the opposite side to the other molar that I left. So I left one molar on each, one upper opposing a lower crown and one lower opposing an upper crown. And then you can see everything ready for the second day. So there's day 2. Day 2, I shot a lot of video that I showed during the webinar. I showed videos of doing the cores. There's different things that we had to do to get the cores to work out well with clamps, etc. So I like to show that because it just helps troubleshoot people and members for their restorative cases. Even if they're not doing a full mouth case, they get tips from that. And then this is just the last part of the video. I just put a little clip in. We're just putting in our second cord. He has a very thick biotype, very thick tissue. So I'm using a second cord that's blue, which the Ultra Pack blue, don't typically use it in the anterior. So this is going to be a physical impression. So I'm going to be pulling these and taking the impression. So when I pull them, I'm using this cord to displace the tissue horizontally so I get enough thickness of impression material so it doesn't tear. So I need a thicker cord in a case like this because he has very thick gingival tissue. So we pack the cord all around, pull it on each tooth because this is the second cord, leaving the first deeper cord in place. And that gives us plenty of space in the sulcus for the impression material so we get a good impression. And speaking of the cores, we had multiple cores to do in this case that day. So it was a lot of work. And you can see different clamps being used. I'm again using core paste, Denmat's core paste, which is self-cured. I've used this for so many years and just had tremendous success. This composite resin and the opposing other side's composite resin I did after the provisionals were in place, because then I know how much to build up the occlusion on it, because we were obviously opening the vertical dimension for this patient. And then I do the quadrants and the preps I do the preps and the buildups and everything in quadrants. So I do the posterior, then I'm going to do the other posterior, then I'm going to do the anterior. It helps me manage freezing as well. In the anterior, I'm using the tooth-colored core paste. In the posterior, I like the white opaque core paste. Here are the crown preps again. Some other views. And then the occlusal view and the impression, the final impression. And if you look here, we've got a little video showing the impressions. So I believe on the upper, I only did one. I didn't need a second. On the lower, we had that little bleed and it wasn't quite right on that molar. So I did a second. But the upper, everything looked so perfect. I just didn't need to put the patient through another impression. And then we make the provisionals. You know, the day before I made the lowers. This day I'm making the uppers. And, you know, typically they go in pretty well and everything's good. There's usually some adjustment, obviously, just because I'm getting very accurate wax up, but seating that over a full arch without any stops, although we had one stop on each arch, is a little bit tricky. You don't always get everything perfect. I'm looking forward to next year printing provisionals and maybe eliminating some of the adjustments that are inevitably needed when you're making them in the mouth. So these turned out pretty good. I needed to do some adjustments, and then I have the patient tested out for the aesthetics, especially phonetics and the occlusion, over a couple of weeks, and then I bring them back in and I do a couple more adjustments. And then ultimately I take off the upper posteriors because we were finishing the uppers first, and take the bites. Obviously, before we do that, we're going to do the 2 composite resins on the posterior teeth. And so here is before and provisionals. So before and provisionals, we lengthened the teeth significantly and didn't really deepen the overbite that much, considering the change in length of the teeth. And that's because we opened the vertical. So we opened the vertical quite a bit. But that's needed because he had worn down his teeth significantly. You know, even just these lower incisors, you can see there's not a lot left. That's why I just didn't feel 100% good about doing veneers on the lower 4 incisors. I typically will choose veneers for my lower incisors. This is one of the rare occasions where I don't. You can see the obvious reason I didn't do veneers on the lower cuspids. I think it's pretty clear. And so here it is as we're testing it. Before and after. With provisionals. These are just provisionals. If you look at my last Dental Excellence video, I showed you how to get the shiny provisional finish like this. He actually dislodged the lower anterior. That's why it looks funny. I had to reseat it. But the upper's been seated and didn't dislodge. You can see how great the tissue looks. Here, the tissue looks a little off because I reseated it right then. But this finish, this super luster to the provisionals, I get that with a product called Glisten. And you can look at my last video to see how we apply that and some good tips to make that even better. And now I'll just jump to the finals because I don't want this video to be too long, but here's the before and after, upper and lower. He did pick a pretty white shade, which I don't blame him. It looks a little bright here because of the flashes in person. It's not quite this bright. It's quite nice. But, you know, if you have teeth that are pretty yellow, A3, A4, you typically want a fairly white smile. And here's the above, before and afters. These are zirconia. We decided to go zirconia, just history of grinding, etc., history of erosion, history of a lot of tooth wear. So I went zirconia, and they're full contour zirconia on many places, except for the facial where they're layered. So the facial's layered to make them look nicer. with some translucencies and things. You can see here they're not quite as white. They've got some nice translucencies to tone them down a bit. Just those other images, I think we overexposed them a little. But you can see here, this was the day we inserted the lower. You can see the tissue's little beat up, but not terrible. And this is a couple of weeks later. The tissue's recovered really nicely. And he's had this for a bit over a year, about 14 months, and he's doing really well with the rehab. So that's amazing. And I posted this to my Instagram. It's actually a popular post on my Instagram. You can see I did a carousel which shows different images of the case. And this was even before the case was finished. And super popular. I had 873 likes, which is a lot. And then I posted the before and after finals. So it was still popular, 488 likes, but probably the people really liked seeing the technique and the step-by-step video shots as I'm working through the case. So that's why that was maybe popular. And if you want to check me out, I'm DRS Phelan on Instagram. And I've been posting a lot more content lately, trying to post more reels and stories I've always done a bit of, but now I'm trying to consciously get at least a reel out every week, and an interesting one with some, clinical footage. So follow my Instagram if you're interested in seeing this kind of stuff. I think you'll like it. And again, this is the kind of case you can complete by implementing what you learn in occlusion design. I actually show this case in the first module, first video of occlusion design, just to show new members what it is they can learn and to make them realize, they can do this kind of dentistry. And as I've said, beautiful dentistry with precise fit and occlusion is not just for the gurus. I feel my members in occlusion design with coaching and following our step-by-step systems can do this kind of case. And we've had lots of members over the many years that I've taught this program and had monthly coaching webinars. I've had many, many, many members complete their first full arch and full mouth rehabilitation case. So, I think it can be done. I know it can be done because I've seen it. And what we do with our coaching webinars is I usually show a presentation like this, although more detailed, usually about an hour to an hour and a half of content with clinical video like you saw, but again, longer, more detailed. I've cut this short for the sake of a YouTube video, but we show some very detailed content. And then we have members submit their cases ahead of time and they're all ready in my keynote. And I just unmute the member and we talk about their case, whether it be treatment planning, troubleshooting, post-treatment questions. It's a great system. I've had members, again, complete their first full mouth rehabilitation and they submit step by step over the months and we go through their case because it really helps to have somebody to kind of talk through your case with, because I might see stuff that you don't see just because I've done so many of these and I've done so many coaching webinars. So I've been teaching occlusion design for 12 years now, going on 13 years. So it's been a long time. So I've got a lot of experience coaching with the coaching webinars. So that's just basically me giving you a preview of the kind of case that I think you can treat with this kind of training. And if you're interested in occlusion design, I'll put a link below where you could actually check out the information page, and there'll be a timer on it because I believe that you need some motivation to make a choice and take action. So there'll be an opportunity to join with a really nice package, but you'll have to basically take action and join within a few hours of clicking the link. So if you're interested, do that. If you click the link and it runs out, it actually does close, I have to say. I can't even get into my links if I let them run out and they close. That's how crazy it is. It's like locked down, it seems. But anyway, so that's basically it. This is a new video for YouTube. If you have other videos that you'd like me to create, I'm happy to do that. I'm trying to get more content created now this next year. Do you like seeing case studies? I can show more case studies. product reviews, clinical pearls. I've got lots of good ideas and different things that I'm going to share. But leave some feedback in the video, in the comments below the video, and I'll use that as inspiration for future videos. So thank you so much, and we'll talk to you soon. Take care.